Good evening, everybody, and it's a pleasure to welcome you all again on this Thursday evening to the appointment, to the January appointment of the series Facets of the Health Humanities. And tonight we have the pleasure of listening to a lecture by Silvia Casini. Silvia Casini lectures in film and visual culture at the University of Aberdeen. She studies the aesthetic, epistemological and societal implications of scientific visualization. And another research interest concerns a visually informed approach to the medical humanities. Her work has been published in international journals such as Configurations, Leonardo, Contemporary Aesthetics, Nuncius, The Senses and Society. Her monograph Il Ritratto Scansione in Italian was published by Mimesis in 2016. Thanks to a Liverhulme Research Fellowship, she has completed her second project, which is a monograph, Giving Bodies Back to Data, by MIT Press, which has just come out in 2021. An examination of the bodily situated aspects of visualization practices around the development of magnetic resonance technology, reframing existing narratives of biomedical innovation. Casini emphasizes the important but often overlooked roles played by aesthetics, affectivity, and the craft practice in medical visualization. She is now embarking on a research project on the contribution of non-fiction cinema to the field of practice of the critical medical humanities. And if I could just add a few words on what she's going to talk about tonight. So the title of the lecture is Visual Culture and the Health Humanities. And, reading the abstract she sent to me in preparation for tonight, I felt absolutely fascinated by what she's going to talk about. Her topic will be on medical images and illustrations, which are important in medical research, in clinical practice and public communication. So in the context of the doctor-patient relationship, the presence of the medical image often enables the absence of the patient's body. And as Orton in 2018 has argued, namely, to be a patient is increasingly to become an image. So bearing upon visual culture and science and technology studies, this lecture will argue for the importance of visual literacy in the field of medicine and hint at some challenges posed by medical images in particular. The lecture will analyze an example of a fruitful art medicine collaborative project that enables the dialogue between different communities, research, the lay public and patients, in view of nurturing a better understanding of and engagement with medical images. And so it's now a pleasure to pass you to Silvia, pass the baton to Silvia. So Silvia, if you could unmute yourself and just take it away.
Yeah, thank you so much. So let me start sharing my screen. Okay, thank you so much, Rossella. Thank you for the kind invitation. As Rossella said, I lecture in film and visual culture at the University of Aberdeen, and I would like to stress that my courses are attended also by students in medicine and in the medical humanities degree. So a little bit of more shameless self-advertising. This is the book. It's the real thing that has been published a few months ago. And so I would be very, very grateful if you are interested in it. Please drop me an email. And if you consider the possibility of ordering it for your library, that's really appreciated. Today, I'm not going to present a paper, but I'm going to offer what I hope are some helpful insights onto different topics that I think are crucial for an understanding of the relationship also between visual culture and the medical humanities. I'm going to tackle the problem of visual scientific literacy, visual science literacy. I'm going to show you a range of medical images that belong to different periods in history to really argue for the difficulty of defining what a medical image is. And therefore to to pay attention rather to the different uses, functions that medical images played across history. I'm then going to mention the fact that visual culture is quite crucial for the field of medical humanities, because nowadays the doctor-patient encounter, the doctor-patient relationship, which is the so-called primal scene within the scholarly literature in the medical humanities, it is increasingly mediated by an image. So the image is central to not only have the possibility of a better diagnosis, so that therefore the importance of an image of quality to enable a better diagnosis and a better intervention, but it is increasingly taking the place of the patient almost in this doctor-patient encounter. And what does this mean? What does this mean when this encounter is increasingly mediated by an image? I'm going to then end the talk by talking a little bit about an art-medicine collaboration that I didn't carry out firsthand, but that I engaged with in my book. And it's the work carried out by the visual artist and photographer Liz Orton. The project is called Digital Insights. And I think it's particularly interesting because it doesn't only show how medical images can travel outside the laboratory and clinical context, but also it poses questions that have to do with visual scientific literacy, and also that have to do with this triad between patient, the image, and the doctor. So let's start with visual science literacy. Images are at the center of science communication, but do we actually have the competence to navigate through and decipher really this visually dense environment that we live in? What is visual science literacy and how we can test it? There's an interesting article that I invite you to read, written by Massimiliano Bucchi, who is one of the leading experts on public understanding of science, and Barbara Saracino, which is a study to test empirical indicators of visual science literacy in the context of a periodical survey of public perception on science and medicine. And part of the survey consisted of iconic images that could be found in science communication. I'm not going to go into the details of the article, but I'm willing to discuss some of the findings. The article found that an image like the double helix, the DNA double helix, or the image of the in vitro fertilization were significantly more recognized by the public than the image of Niels Bohr's original model of the hydrogen atom. With regard to familiarity with visible scientists, perhaps not surprisingly, more than 90% of the respondents correctly recognized the face of Albert Einstein. Another interesting finding was that science literacy measured by textual questions rather than by images is lower than visual science literacy. As I said, scientist portraits were very much easily recognized. And then both science literacy via textual means and visual science literacy would increase with the general educational level of the respondent. Let me say that one of the flaws, I believe, of the methodological approach used by Bucchi and Saracino relies in the type of visual material that they've chosen as indicators of visual science literacy. Are we sure that an image like the one of Einstein's face has to do with visual scientific literacy, or does it have to do much more with the power of such images as cultural icons? Bucchi and Saracino obviously seem to be aware of the fact, and I quote, "Of course, recognizing an image associated with science like the DNA, double helix, or Einstein's face does not necessarily imply conclusions on specific knowledge of content on the part of the interviewees. Still, familiarity with science images could provide a relevant hook for science communication strategies," end quote. So these images can function as anchor within the context of a better communication of science and medicine. But the article does not actually engage with how images work within science and medicine. And to do that, I think, and really, this is where visual culture, I think, can have something to say. For example, the field of visual culture can help clarifying the terminology around vision, visuality, and images, and to bring in some clarity, terminological clarity when we talk about images. Just to give you an example of actually what is a heated debate, really at the level of terminology. There's a shifting terminology in articles that engage with visual culture and medical humanities. But I try to kind of give examples of the definitions of some terms. Vision and visuality, for instance. Vision denotes all the anatomical, physical, and geometric aspects concerned with the act of seeing. Visuality is the bundle of social factors involved in the act of seeing. Representation is used quite often, but is not always a suitable term because it is very often burdened with a reference to an independent object. So it tends to be replaced by the term visualization or rendering visible to highlight really the active aspect of image making in scientific practice. Visualization is another term that we encounter that has to do with any human-made visual pattern, a diagram, a radiograph that renders an object or a fact perceptible to the human eye. Visualization can obviously occur also by means of an instrument. Imaging is specifically used in the medical and scientific context in lieu, sometimes of visualization, to describe particular procedures and equipment and the problems involved in their application. And the term has become primarily associated with digital media, okay? So this is just to give you a sense of even the richness of the terminology that we find whenever we want to talk about images within science and medicine. But if we actually start to look at, what type of images we find, well, we can really find a huge variety of images belonging to different periods and made with different techniques. Anatomy is an example. Anatomical images are an example. Anatomy is obviously one of the oldest medical science. And as we know, in antiquity, the body's internal structure was the subject of speculation, fantasy, and also some study. But there were few efforts to represent it in picture. And it is the invention of the printing press in the 15th century that helped inspire this kind of new spectacular science of anatomy, this dream anatomy that reveals as much as of the outer world as it does the inner self. Then we know that over the centuries, the science of anatomy has embraced the vocabulary of realism rather than this kind of imaginary and dreamlike quality. Here you see an example that I like to show also to my students, coming from the Fasciculus Medicinae by the Kentham. This little bundle of medicine was a small group of independently authored medical treatises and illustrations. And it's one of the earliest illustrated medical books to be printed. And then the original version was in Latin, but then it was translated into the major European vernacular languages. And it's interesting, this treatise, because it does reflect, if you want, both medieval ideas around the body. And for instance, we find many diagrams copied from medieval manuscripts that shows also the growing importance of empirical investigation on the interior of the body. And we find also more almost modern-like narrative-based scenes that demonstrate the modern taste for classical styles in figures and interiors. So this attention, we already find in this bundle of treatises, the idea of the importance of an empirical investigation of the interior of the body that then will become much more prominent with the work of Vesalius, for instance. Or to give you a flavor of other types of images, well, we have engravings or drawings made with the microscope, made, using also the microscope. And we know that the microscope, it's one of the instruments that played a major role in the development of scientific medicine. And it's kind of interesting to see that sometimes we find a microscope accompanied with drawings or engravings. And in some cases, with the advent of photography, we see the combined use of photography and microscopy to create better images, to create really images that became the epitome of mechanical objectivity, to use the term of Daston and Gallison. So the objects seemed almost to draw themselves, okay? A human artist was not involved anymore. So let's remember that photography for Talbot was the pencil of nature. And I think this is an interesting point, because as we go along in history, we find other examples of this skepticism toward the human senses, the idea of creating, inventing instruments that would replace the human sensorium and its flaws. Okay, here you see, for instance, an example of the visual output of instruments that were produced, created, invented by Etienne Jules Marey in the 19th century in physiology. And these were self-recording instruments. So they were instruments that would enable to analyze, record, and also break phenomena down for extrapolating values and constants. It's quite interesting to see that the type of visual representation is not a mimetic image, but it is a graph. A graph that is able to translate the language of bodily movements into readable displays, okay? I can't really forget to talk just briefly to mention the use of moving images in medicine. And here I wanted to show you an example from what is the world's first documentary film made by the Romanian neurologist Marinescu. Marinescu perfected the use of cinematography as a research method to investigate gait disorders and hysteria. And it's interesting because in his films, the film and moving images played different but also overlapping functions. First of all, they were means to really conduct an experiment and to explore a phenomenon, a condition. They were also a document, a form of documenting a case and of archiving a case. And then they were used as an educational tool also for didactic purposes, but also for the purpose of sharing knowledge with other peers. So moving on in this very, very sketchy history of you know, the variety of medical images that we can encounter, I also wanted to show you the scan, the first cross-section nuclear magnetic resonance scan of a human chest. That was obtained by Damadian, a US-based doctor, who was the first to really push for the development of MRI from a purely research tool into a clinical tool. And here, without really going into too many details, I wanted really to give you a flavor of the variety of visual representation. First of all, this laboratory sketch that contains really a diagram, more than anything else, a diagrammatic representation that is made of a matrix composed of columns and rows, filled with numbers that represent a certain parameter, the so-called relaxation time, the T1 value. And then you see here the same image, but conveyed in a different way. So the image itself, rather than the raw data. And I think this is quite important for us to keep in mind, because with the advent of computer-assisted imaging technologies, so after the Second World War, medical images are actually become image data. And I think this double belonging is quite interesting to study. And it is also the area that perhaps poses some of the problems for scholars in visual culture and medical humanities. I said that I showed you really very briefly a variety of medical images that we can find across history. And I think that one of the red threads that we can highlight perhaps is the fact that all these images reveal somehow the attempt to access, to explore, and to visualize the body and also the interior of the body, okay? And perhaps one of the iconic images that embodies this attempt to visualize the anatomical body, that is the body composed of organs, of tissues, and the anatomized body, that is, and the body composed of molecules, of cells, is this image coming from the Visible Human Project. I like to show it because it does embody together this kind of three phases, these three historical moments in the representation of the body in medicine. So from anatomical dissection through to the invention of X-rays, so the possibility to access the interior of the body without having to cut it open. And then this idea of the molecularization of the body that was facilitated by research in biomedicine and genetics, but also by the advent of computers, okay? And you see here, you know, the presence of the two-dimensional anatomical image, and then of the three-dimensional images that make the body increasingly rendered as a series of pixels, okay? So this is really just to give you a flavor of the complexity of the field of visual culture and medicine, that whenever we talk about a medical image, we need to be very careful in trying to use the right terminology and in trying to really contextualize also contemporary images to kind of understand the history behind them. The cultural historian Jonathan Sodey pointed out that the sense of interiority is inescapably central to the experience of the body within history. Then I read a little bit further. We may become familiar with the generalized topography of the body via different media. Photographs, X-rays, illustration, anatomical illustration, written description, TV documentary. But all these voyages within are journeys of exploration which encounter bodies other than our own. They are passages into the body, but not my body. And I would like to invite you to keep this in mind, this idea of the encountering the universal body rather than my own body, and the difficulty of encountering my own body via these increasingly powerful technologies. Let us just briefly mention what is at stake today when the so-called primal scene that I mentioned before, so the doctor-patient encounter, is increasingly mediated by an image or by a set of images. We could say that to be a patient is nowadays increasingly to become an image, that the image precedes, enables, verifies every intervention in the body. That to go into the body means going into the image first, very, very often. That in some countries, the patient is not even allowed to see her own images. And that, as Liz Houghton says in her book, Becoming Image, Medicine and the Algorithmic Gaze, and I quote, "The medical image enables the absence of the body," end quote. Let us think about what happens when there's a multidisciplinary team meeting, for instance, in the National Health Service in the UK. We have professionals from different clinical disciplines, oncology, radiology, and so forth, who come together to discuss images of each listed patient to reach a consensus on the individual treatment to recommend, on the procedure to follow. And only after this MDT meeting, the chosen intervention is presented to the patient. But many of these scans are interpreted with little details about the patient or the symptoms. only a tiny proportion are discussed in multidisciplinary meetings. So paradoxically, the more scans are performed, the less time is spent on the interpretation of these images. And increasingly, these images generate and define the patient into binary categories, disease or not disease. It is through medical images that very often one takes a decision, a doctor takes a decision in favor or of or against an intervention. And clearly it is important that the images are images of quality. So I'm not suggesting that we should get rid of medical images, that this, I'm absolutely highlighting the importance of having at our disposal reliable and good quality images to enable a better diagnosis and intervention. But what actually happens when these images are increasingly used within the doctor-patient relationship, when they are really the mediators of this relationship? And I am thinking to push the reflection even further, because, for instance, artificial intelligence and machine learning techniques are the fastest growing sector in medical research, okay? Although few applications have reached the market so far. But clearly, when we talk about images, we are increasingly talking about operational images, images that are made, not only that are made by machines, but that they are also made to be seen by other machines rather than by human eyes. What kind of implication does this have for, again, for the doctor-patient encounter? I think to kind of give you a sense of how, to some extent, concrete these problems can become, I want to show you a very simple radiograph, and to kind of offer some questions for our discussion later on. So what type of visual evidence is produced here? What remains hidden from view? What sensorial modalities beyond sights are neglected? Whose body is affected? Where is pain in this picture? We see the circle here that highlights that something is not quite right in the image, in this part of the body. But is pain here? Is pain really made visible here? And this question is important and enables me to really enter into the last part of my talk that is related really to the interventions that visual artists can make into the field of medical and health humanities. And I want to briefly discuss the work of the visual artist and photographer Liz Alton, because I believe that her work is extremely important in really tackling these problems of visual literacy, visual science literacy, and also the doctor-patient encounter mediated by an image. Interestingly, as it happens for several artists, for other artists who work with medical technologies or medical images, Liz Alton too starts with a personal experience, exactly because to actually get hold of medical images is obviously difficult for privacy purposes. So the first way of actually engaging with these images is if you are a patient, or if you have or if you want to volunteer within a research project and act as an experimental subject. Or, as in the case of Liz Alton, if you have someone who has to undergo a medical procedure, and she describes the experience of her daughter. And this was really the kind of the trigger for Alton to think about really the experience of undergoing, in this case, a nuclear imaging scan. And the idea that these technologies are presented as non-invasive technologies. So this idea that you don't have to cut the body open anymore, okay, to access the interior of the body. But actually, as she says, but perhaps this technology cuts into the body in other ways. Medical images, with their promise to visualize the unseen, seem to transgress emotional and psychological boundaries. under circumstances over which we have very little control. And the experience that patients describes is increasingly intensely vulnerabilizing, okay? And this is not a personal story, as Autumn highlights, but it is really a story that is shared by so many others who had an experience of undergoing a medical imaging procedure. And it is really this personal experience that is the starting point for the project Digital Insights. A very interesting project in which Autumn availed herself of a variety of sources, including medical imaging, radiographic manuals, data from patients' bodies. It's a project that was supported by the Wellcome Trust. And it's quite unusual in the field of medical humanities because Autumn is not interested in producing art for therapeutic or healing purposes, but she's really interested in working around images, medical images. And she stages a dialogue, different dialogues with patients, but also with the scientists, the radiologists, the doctors, to explore issues of image ownership, trust, consent, and language. In terms of methodology, Autumn used medical images to trigger a conversation with different patients or with a scientist, with a radiologist, for instance. For each dialogue, the patient could choose around 5 images from their own, medical examination. So the images that belong to the patient. The dialogues touch upon the medical images on display, but they are not trying to clearly establish any direct correlation between the clinical condition, the image, and the conversation between the patient and the artist. It is as if Autumn were more interested in creative and active space for listening, which some feel is becoming a lost art in medicine. So Liz Autumn tried to create, to not only bring the images, these medical images outside the clinical context, the diagnostic context, but also to create a kind of non-scientific and vernacular language by means of using a visual-based methodology. And it is thanks to a vernacular language that perhaps a better understanding also between patients and doctors can happen. And I'm reading a passage from an interview I had with Autumn. The patient is infantilized by the lack of a colloquial language, this idea of a vernacular language. Medicine is for the protection and safety of the patient, but patients describe the disembodying, silencing, and infantilizing experience they undergo by the impossibility of seeing and talking about their own images. So this is exactly the type of action that Liz Autumn is interested in carrying out, giving these images back to the patients and giving them the possibility to talk about their own images, to own the images again. And before I conclude, I want to give you just a sense of really the method of Liz Autumn, which is interesting, I think, because it is a mix of a textual-based and visual-based methodology. So I think it's interesting for those of us who are interested in narrative medicine, and for those of us who are more interested in like an image-based strategy in the medical humanities. Here is a passage from an extended conversation that she had with a computational medical imaging scientist. And I'm not going to read through the whole dialogue. I'm going just to point out at some of the questions that Autumn and the scientists are discussing. First of all, Autumn doesn't start with a medical image, but she starts with this image here, which is a satellite image. And it's interesting, this choice, because the satellite image gives her the possibility to bring up the idea that very often scientific and medical images are interpreted as if they were photographic snapshots, okay? When they are image data, when they are the result of complex procedures of transformation that involve different professionals. And she uses this this image to start to trigger this dialogue with a scientist. And she said then, that's when I emailed you the question about what is gained and what is lost when a patient becomes an image. The scientist replies, blurring, intensity quantization, movement of patient or organs, physical measurement as an approximation. All these things might degrade the image. And then Autumn says, you said, I find it easier to summarize what is preserved in a medical image than what is lost, I think, a great deal more. What are medical images exactly? And it's interesting that they try to really work together, to achieve a working definition that might enable them to start really talking the same language, more or less. So this idea of creating a vernacular language, a colloquial language to talk about images that are highly complex, okay? So visual measurements, it's a non-optical image. And the scientist replies, I suppose it depends what you mean by image, what's the definition? And he seems to be keen to call these medical images a matrix, okay? It's just to be processed. It's just for computational means. And Autumn asks, what happens to the raw data, the original capture data, before it has been processed? And the scientists, I'm thinking we need to go back and define our terms. The way I think about images is that ultimately, that term covers any data that is meaningfully arranged in a two-dimensional regular structure. If it is numbers in a regular grid, then it's actually an image. It can be recognized as an image. It can be recognized as an image, not necessarily also by human eyes, okay? So Autumn and his computational scientists do not speak the same language, okay? But they are still able to engage into a conversation, into a dialogue. Also, thanks to the images that are really they are really the anchors for this conversation. And it's not just, as I said, it's not just medical images, but it's also scientific images, or even hand-drawn sketches that the computational scientist makes as they talk. Okay, I would like us to keep in mind this question that Autumn asks, what is gained and what is lost when a patient becomes an image? I think this is a central question. How would you answer that? Perhaps we can start our conversation from that question. And this is the final example that I give you from Digital Insights, from the Digital Insights project. This is an example of a dialogue that Autumn carried out with a patient, this patient, Ida Levine, who struggled to recognize herself in a medical image. For Levine, relating to her own medical images, as she explains, was troublesome for the traumatic memory of the procedure that she had to undergo, a mastectomy. So the images were evocative of that traumatic memory. So Autumn, the artist, decided to print out the images and to see whether this kind of feeling also of estrangement that the patient described would change. As actually these figures show, once holding the images as prints, Levine personalized them. She marked them. She tried to give them another context. She recontextualized these images, also with maps and images coming from her childhood, from her own story. So by controlling the images, the patient can take back a bit of control of her own medical experience. And again, the dialogue had the very same structure of the dialogue with the scientist. But the kind of difference here was the idea that Autumn had of also printing out these images. So overcoming the idea that medical images are so often accessed by, a digital interface only. And I think it's quite it's quite powerful also to read this dialogue, to read this conversation, because I think it kind of gives a sense, it gives it makes us understanding also what Jonathan Sode was talking about when he was talking about this inability of actually recognizing one's own body when, you know, in this kind of journeys inside the body. Levine says, on the one hand, it's medical, but it's also really personal, talking about the medical images that she got. It's me, but it's also not me. We don't have a language to judge our insides, but for the outside, we have a script, especially for women's body. And Autumn then says, the ability to scan people so easily is turning medicine on its head. And this is why I brought in the discussion on the multidisciplinary teams meetings and the idea of introducing machine learning into the field of medicine. I think these are the conversations that we need to have within the visual medical humanities. Then a little bit further on, the patient says, I trusted the power of the image and the doctor to give a definitive answer. This is like the hope, obviously, that the image will provide a reliable visual evidence that will enable a decision for a treatment or for a diagnosis, and etc., etc. And Levine concludes by saying, you are totally at the mercy of the people and the process. So this feeling of being disempowered while undergoing a certain medical imaging procedure, you need to comply so that they can get what they need. Later, the care I had was absolutely amazing. The doctor looks at the images, just another spine, just another breast. For the patient, it's a very personal story. My experience is that they give you the results, but you never see the images. So to conclude, I believe that there's a radical potential for art interventions for the field of medical and health humanities. Artist interventions can help medical humanities to move beyond the role of a supportive friend for medicine, providing innovative visual-based qualitative methodologies for exploring and also perhaps improving the doctor-patient relationship that is increasingly nowadays mediated by an image and by data visualizations. And then visual medical humanities can foster better visual scientific literacy. So the ability to see and even read a scientific or a medical image, moving beyond the purely narrative dimension of medical humanities based on literature and storytelling. We need to pay attention, much more attention to images in the field of medical humanities. And then artist interventions can also contribute to scholarly research and discussion onto scientific objectivity, issues of trust, the ethical use of images and data coming from patients' bodies. So I think that these are, from my very, limited point of view and knowledge, some of the ways in which the collaboration between visual culture and the medical humanities can really be fruitful. Thank you. Okay.
Thank you very much, Silvia, for the very rich presentation. Very fascinating about imaging. It's the first time, and you know, you talked about the very rich vocabulary about vision, visuality, and you know, you explained it at the very beginning, and actually I didn't know anything about that, you know, so it's actually really interesting how, you know, the vision, what we call the vision, what we can see, then it can be conflated into something else within the social, you know, with whether, you know, we looked at or we look at or we look at ourselves, because this is very much the need to be able to see ourselves rather than to be looked at. And the history of that was very fascinating, from the Middle Ages to the very refined technology that we have these days, where we can be seen from the outside and from the inside without a name, even, you know, in a very anonymous way. I remember a friend of mine, he's a radiologist, and during COVID, he was scanning and he was x-raying hundreds of patients in the hospital, and all he knew about these is, you know, when he saw the coronavirus in the lungs, he didn't even know their name, he didn't know who they were, but all he saw was the imaging of them, and he was sending some to us and saying, look, this is what it looks like. I found that really scary, actually, because I thought that could be me one day. So you know, in order to start a debate,
I ran a bit late. I apologize.
no,
We
no,
started a little late.
it was really good. It was really, really fascinating. And I just wonder if I could maybe open up the debate with a question and then open it to the public. So I'm going to keep the probably the speaker view, and I'm going to put it on just the two of us, because I think it's probably better. Okay, so
I made you the host, Rossella. So
am I the host now? Good, yeah. So it means that I can put the spotlight on people as they speak. It's okay. So my first question, Silvia, is we're going back to Foucault, who is the first one who talked about the medical gaze, you know, and this division, this kind of wall that started to be erected between the medic and the patient from about the second half of the 18th century, you know, where during the Enlightenment, you know, when everything is percolated and filtered through the reason, and we lose the benefit of the relationship that you talked so much about, you know, because you were saying very clearly, you know, we have the image here, you know, this is the spot where maybe the either coronaviruses or the pneumonia or the cancer or whatever, but does that talk to us about the pain, or is it just a flat? And then more and more technologically advanced techniques, like, for example, microscopy and photography. So even the human being is outside the equation. It's just like a matter of, and it seems to grow more and more. You know, you showed us this kind of, you know, meeting of doctors that before they give the patient the good or bad news and how they're going to treat it, they have this mini conferences of say what we're going to do about that based on an image without the patient there. And also, having lived in this country, I'm sorry if there's any British people, we're never given images in our hands to take home by the doctors. We are just given a result, or we're not even told anything. If you don't hear, everything's fine, which for me really raises anxiety. Well, in Italy, maybe where we come from, most of us may be here tonight, we get the imaging in our hands and we go back and forward between the doctor and the specialist. But we have an idea that we can put it against the window and see, you know, we are kind of owners of our own images. What is the future, do you think, of being able to own ourselves, to own our images, to be able to become again I suppose, the leader of our own experience of, you know, I work in poetry. I work in especially autopathographies through poetry. So it's usually poets that have experienced illness and that have written through it. And in a way, that's an imaging, isn't it? It's imaging through words. What do you think would be the best way forward of allowing for medics, of allowing patients to again become empowered in their own therapy through images? And I know you've talked about Orton, which was amazing, but it sounds it sounds like more like a research project to me. But how about the common patients? You know, me and you, and you know, people in the streets. How would you?
Yeah, I mean, it's a very difficult question. I think it's, I mean, to me, an important thing is to, and the reason why I think Autumn's project was actually very interesting, and it was actually carried out with, you know, real patients. It was not based on, you know, pure research. But I think it's important to not like the line is very thin, because on the one hand, one doesn't want to question the expertise, particularly nowadays, of, you know, those who have the knowledge, the again, the expertise to make a diagnosis based on images, but based on, you know, a variety of other means, the biomarkers, etc. But on the other hand, there's this idea of, you know, not losing sight of the kind of patient's voice. I don't have a question on how the patient's voice can take a prominent role, but I do feel that that the idea of being able to own, being able to access one's own medical images is actually important. Those are data. I know that there are different policies in different countries. In the US, it's one thing; in the UK, another; and in, yes, as you said, in Italy, it's another. But I think that I feel that artist intervention can at least open the debate, or can point out at some problems that I think for the majority of people remain at a very maybe intuitive level, but they are not necessarily further elaborated on. I'm very careful in trying to find a space that in between the kind of extreme position of saying, oh, we shouldn't trust experts and we should, you know, basically do whatever we want with our, you know, images, and the idea of having more power, of feeling less disempowered. I think the problem is to find ways of establishing again a sort of more horizontal relationship with between doctors and patients. I'm very much in favor of actually a listening mode, like the idea of actually getting more time to actually talk about one's symptoms, one's, you know, one's pain to some extent. And I think that the lack of time that is increasingly related to the lack of resources and funding, thinking about the NHS in the UK, is the problem. I do remember, like, the personal experience of having a 10-minute appointment maximum with a GP and being asked to, well, you can talk only about one thing. You cannot mention, you need to take another appointment. So if you have, I don't know, 3 symptoms, you can actually mention the 3 of them. So that was my own experience. So I don't have an answer. I think it's a very difficult question to answer. I do believe that we need to nurture more projects taking place within hospitals, with clinicians, with radiologists, with medical researchers. But we also need to increase the visual, scientific, and medical literacy in everyone. Basically, we need to kind of not always try to measure, you know, the knowledge of scientific facts transmitted by means of words, but also, you know, we need to make sure that people are able to understand, even very simply, what an image is actually representing, what are the techniques behind it, whether it's again a photographic image or it is an image that is, you know, made by, you know, using algorithms, etc. I think increasing visual scientific literacy is paramount to feel more empowered, because I think that the feeling, it's not just a question of not owning or not having access to one's own medical images, but it is also a question of feeling that we can't really understand that. We can't even grasp what they are to some extent, because they are not mimetic in many cases. And I'm not thinking about, you know, a radiograph or you know, other kinds of images, but in some cases, again, and we do, when we see them, we take them very often as, you know, as if they were photographic snapshots. We are not trained enough also in statistics, probability. So all these dimensions and disciplines do play a huge role in the image making procedures in contemporary biomedicine.
Yeah.
So,
yeah, I totally agree with you. Whether you mentioned listening, you mentioned education, I suppose, and then the horizontal relationship with between medic and patient. So it's going back basically to a relationship between medic and patient, which is well, unless you go privately, with private medicine, you're paying someone, they spend more time with you, they explain to you more what is going on, and I've got direct experience of that.
If I add something, Rossella, before I forget, I also think, because when I teach students in medicine, I'm always struck by realizing, and I'm talking about the UK, obviously, where the kind of education in at high school level is very much different from, for instance, from the very generic education that we receive in Italy. So I'm always surprised by the fact that sometimes people who are going to become doctors are not familiar with the history behind the instruments that they use and their ways of seeing. Okay, because each instrument has a way of seeing. Each visual output is embodied in and has a long chain of you know, a long history, basically. And I think this is also what I mean by actually visual scientific. So in this case, it's not visual scientific literacy, but it is visual literacy that we need to nurture in you know, in future doctors, for instance. I think that's an important role for people with a background in the arts and humanities or social sciences.
Yeah, I really believe in the collaboration between arts, humanities, and medical and scientific, and that we've, you know, well, I suppose if we go back to the Renaissance and to even the Enlightenment, you know, people were actually educated in all you know, disciplines, but now we're very sectorial, and so, you know, all you know is just modular, even, I would say. But it is that specificity and that specialism that each of us has that sometimes stops us from communicating with someone who does something completely different. So medical humanities have got a lot of potential, really, for the improvement of life, I suppose, and of medicine and you know, illness and relationships between the medic and the patients. I also like the idea of, you know, Orton using satellite images and using, you know, next to the microscopic images, and saying, like, you know, how many instruments can you use to see the same thing, and what kind of distance or closeness and I suppose perspective can you have on yourself. You know, you can see yourself from far away or from really close, and it's still you, but it is still you. Because I suppose, as a person, and I really believe in storytelling, and this, you know, the voice and storytelling is so much more conflating the two-dimensional image into, you know, kind of an all-round person and what it is to be a person and alive and suffering, especially. And that can only be done in relationships, really. It can only be done by relationships, by exchange and listening and talking to each other. which is very much lacking, isn't it? Also quite like the infantilizing, you were talking about infantilizing and using a more vernacular language. And so you don't want the jargon, which is really only for the few, for the doctors. But at the same time, in order to explain the jargon, if you dare to say a word which is half scientific to a doctor, and that's happened to me, and I also work as a nutritional therapist, and I do have a background in science because I've got a degree in nutrition. And I say that to someone who's giving me a scan on my shoulder and say, look, because I think it's my rotatory cuff, I said at one point. And he said like, oh, you're very clever. You're very clever, aren't you? And I was going like, excuse me. And say, yeah, well, thank you very much. Or, you know, you go maybe, just another example is, with the doctor here, someone has a UTI, you know, urinary tract infection, and you say like, when, you know, you go and then maybe you've got a urine infection, and they go like, oh, really, is it a water infection? And I go like, no, I don't have a water infection. My water at home is fine. You know, my water jug is fine. It's a urinary. There is this kind of lack of connection because they feel that you don't understand the language. And they refuse to talk their own language as if, and I found a huge difference between Italy and the UK here. Now, I don't think that Italy's got the best answers yet either. I don't know, it's probably a problem, but I wonder if Orton had thought about storytelling as well.
I mean, I can't obviously. I think you should invite her in the future, maybe, and to one of your meetings. But I do think that her kind of visual-based dialogues are an instance also of storytelling, maybe with a kind of storyboard almost. But I don't see a refusal of a textual way of working, and in the end of the day, what the patient, Ida Levine, was discussing was actually her own story as a patient. It was really about her own experience. So there was definitely, I think, an instance of storytelling. But I do think that the risk, and again, I'm a visual culture, visual studies scholar, so I do find that the risk sometimes in narrative, like medical humanities, is to really hush over to kind of not pose enough attention to a close reading also of the images, or to use images as, you know, ways of maybe illustrating an argument, or of, you know, accompanying the words, so to say.
Yeah.
I think that the work of James Elkins, the art historian James Elkins, is very helpful in this respect, because it does help to stay close to the picture, as much as we try to stay close to a text.
Yeah. It would be quite interesting to collaborate, to have, you know, kind of images, even if it's, you know, microscopial, satellites, or even artistic, I suppose, next to I suppose a kind of I don't know, I suppose your story, or a kind of a conflation of what it is to feel that, you know, your condition is comprised and is encapsulated in that image, and then
Also,
sorry, no, a bit like I'm thinking of a poet, and then I'm back in poetry here because it's my specialism. There's a poet, Antonella Nedda, in Italy, who actually works very much between images and words, and so poetry next to images, and it's very much like a testo a fronte, no, with a translation next to it, except it's the translation of the image, but it's not medical images, it's more connected. It's a story about pain, it's a story about illness, but it's connected to artistic images usually, and I'm sure it could be done exactly with imaging from medical.
I remember there's an interesting little book written by John Berger, who wrote Ways of Seeing, this kind of famous landmark book in visual culture. And it's it's called A Fortunate Man. I think the story of a countryside doctor. Okay. And it's an amazing book because it does exactly manage to be about storytelling, but also to use photographs. So it's a collaboration between the writer, a photographer, telling the story of this doctor, and I think that's a book worth reading, really. To kind of.
What's the name of the author again?
Let me post it into the chat. There you are.
John Berger. Okay. I know that's definitely a book to buy for me and read. So, are there any questions from the public? Anybody would like to contribute a question, or even write it in the chat, and I can read it to Silvia. So, okay. So, well. Maybe it's a good moment to close. Thanking Silvia again for a fascinating lecture, really. And Teresa, did you want to ask something?
Oh, I wanted to thank you for a very, very interesting talk.
Yeah. Thank you so much. Thank you, Teresa, and thank you, everyone. Thank you, Rossella, for inviting me. And it's quite late. I know we are all probably hungry, and so thank you very much.